1.4. Okay. Round down. Yeah. Hold that question for our panel. Yeah. We took a picture, sent to. Yeah. Now it's time for you to know everyone's kids so that they come here. Right? Go to every wedding, catch them all. My hard stop is okay, 12.
Good morning, distinguished guests, speakers, faculty, students, ladies and gentlemen. On behalf of the Board of Governors of Ahmedabad University and the Board of Management, it is a great pleasure to welcome you all to the inaugural Ahmedabad Dialogue on the Business of Health. Ahmedabad Dialogue is a top-tier thought platform of Ahmedabad University. It is designed as a deep dive interface of academia, industry, policymakers, and practitioners from India and across the world. Ahmedabad Dialogue aims to enhance understanding of critical issues and hot-button topics and advocate positive outcomes for society at large. I now invite the Vice Chancellor of Ahmedabad University, Professor Pankaj Chandra, to share his thoughts about the necessity and importance of the Ahmedabad Dialogue and also about today's inaugural Ahmedabad Dialogue on the Business of Health. Professor Chandra.
Thank you very much, Sudeep. Welcome to Ahmedabad University. Dr. Vinod Paul, member Niti Aayog, Professor Niyati Parikh, visiting faculty at the Bakshi School of Public Health, and Associate Vice Provost of Faculty Initiatives and Global Engagement at the New York University. Dr. Atul Kochhar, CEO of NABH, Dr. Rashmi Nandargi, VP Bajaj General Insurance, Dean Kamadi Joshipura of the Bakshi School of Public Health, my colleagues Sudeep, Anindya, and ladies and gentlemen, it's a pleasure to welcome you to this Ahmedabad Dialogue. You know, Ahmedabad University is a very young, liberal education-driven research institution with a single-minded purpose of advancing the self and the society. We feel that these two are very deeply interconnected. And academic institutions like ours actually contribute in two different ways. One is through what our faculty do and their impactful research, the questions that they ask, and through our graduates and what they go ahead and do. And this is the purpose of building critical and independent mindedness that allows to make our deeper and build the capabilities that the country requires at this particular juncture. Ahmedabad Dialogue is a product of that perspective and imagination. You know, our world is getting disrupted very dramatically by geopolitics, by climate change, by technology, and urbanization. All of these are forcing us to rethink the assumptions of the past in the way we live our lives. And Ahmedabad Dialogue is an intellectual platform where, away from the glare, one can think about critical issues of this kind. And what are the impact of the drivers of these and other changes that are happening in the larger society? At Ahmedabad, we live in Pasteur's quadrant. This is addressing problems that have immense relevance but require deep rigor to be able to engage, understand, and find solutions for them. As a consequence, Ahmedabad Dialogue is aimed at bringing, as Sudeep said, academics, policymakers, practitioners in a quiet space to think about our challenges and these wicked challenges that the society faces in the spirit of inquiry and solution finding. The dialogue for today is the business of health. The business of health is the business of science in the society. It is one of the most critical issues facing the nation. From environment to AMR, from nutrition to prevention, from drug dispensing regimes to self-medication, from data on health to public policy. These are the real questions. And the bigger question above that is, what kind of philosophical mooring do we have in the larger society to address questions of this kind. So we at the Bakshi School of Public Health are the anchor for the Ahmedabad Dialogue for this year. And we're hoping to build an interdisciplinary view on many issues of this particular kind. And not only that, but also to be able to build suggestions through the roundtables that are happening through the day, to provide inputs to the variety of collective thinking that we will do today and in times to come. So welcome once again to Ahmedabad University and to Ahmedabad Dialogue. Thank you.
I now invite Professor Kaumudi Joshipura, the Dean of the Bakshi School of Public Health, to introduce the Ahmedabad Dialogue on the Business of Health to you.
Good morning, everyone, and a very warm welcome. Excuse me. A very warm welcome to our panelists, Dr. Vinod Paul, Dr. Rashmi Nandragi, and Dr. Atul Mohan Kochar, and to the audience, which also has a lot of very esteemed people, and to our people who've come from all over the place, and to Dr. Niyati Parikh, who will be moderating the session today. So I'm going to talk a little bit about our School of Public Health, but more in the context of public health in general and why public health is bringing this business of health. So this is our slogan: let's move together and step well to improve human and planetary health. Just want to acknowledge our wonderful funders, Mr. Smita Bagchi and Mr. Subroto Bagchi, who have also given philanthropic contributions to many other institutions. So, can everyone hear me at the back? Okay. So as people are familiar with the UN SDG goals that we are all working towards, Goal 3, there are many goals that actually apply to health, but Goal 3 is very specific and on good health and well-being. The goal is to ensure healthy lives and promote well-being for everyone across the lifespan. So when we say everyone, it's not about giving equal access and equal opportunity and equal resources to everyone, because there are people who are underserved and they need more resources. So the concept of equity is very important, and the distinction between equity and equality as we think about different actions we may take. So what is public health? If we ask lay people or even educated people, most of them will say it's about giving free treatment to poor people. It's not that, because that's at an individual basis. Public health, we step back and try to look at the population as a whole in our methods, in our approaches. So as WHO defines it, it's organized measures, which could include policy, community action, as well as addressing commercial determinants to prevent disease, promote health, and extend life for the entire population while creating favorable conditions for health. Some things can be done at individual levels, but a lot of actions have to be taken at a large population level. So what are favorable conditions for health? We need a healthy planet, clean air, safe water, healthy food options, shelter, infrastructure at a population level. We also need business goals and practices to align. We also need government, community, and organizational policies that would favor health. And this is very important, that everyone tries to make change within the existing culture and norms and say, these are the norms, these are the cultures, we can't do anything different. We cannot make change happen, keeping everything the same. So I think we all have to come out of our barriers, inhibitions, whatever they are, to make bigger change. The mission of the school is to improve human and planetary health locally, nationally, and globally. And this is done by three arms, which is action, which is our driver for the education and research. So we've started our first PhD program in epidemiology, and we'll be moving towards master's programs in data science and environmental health as well. And the research and action and education all kind of inform each other, and they would be aligned. We also have a Sahयोग Center for Promoting Health, which leverages the strength of the academic rigor at the university as well as Seva's grassroots network and their experience in succeeding there. So why focus on non-communicable disease, which is the focus of the today's session and the discussions? Infectious disease come and they make a big noise, and like COVID-19, everyone was aware, even smaller outbreaks in local places, everyone around is aware, and they make a big noise. It's very severe when it happens, and then it goes away. Chronic disease are silent. Most people don't know that the person next to you may have chronic disease for decades, and they have a long-term impact on quality of life, disability, and mortality. Importantly, they're largely preventable through modifiable environmental lifestyle and commercial determinants. And there's a need for intersectoral solutions and prevention. So here at Ahmedabad University, where we have a very interdisciplinary approach, this is, it's very fits with our goal of integrating many different disciplines into this public health. So coming to the business of health, when people think of health, mostly we're thinking of healthcare, which is treatment, pharmaceuticals, medications, hospitals, medical devices. Those are the businesses that are directly related to health, and also diagnosis. So there are many new products, new technologies coming in. Insurance plans and coverage varies from government insurance, private insurance, individual, group insurance. And that determines the affordability, access, and it impacts health and equity. What the insurance covers gets done, what it doesn't cover may or may not get done, even among people who are affording. And government policies have a major impact as well. But to me, healthcare, this is not healthcare, this is mainly disease care. We should make a new word for this. Treatment is disease care. We usually say healthcare, and we're talking about that. Let's move backwards. So we're doing, mostly like community medicine, and many organizations say, no, we want to do more of prevention and other things, and then we're talking about early detection and population-based screening. That's important for many diseases like cancer. If they're detected early, you can address it, it costs less, there's less trauma to the patients and everything. So there are all kinds of diagnostic procedures, laboratories, points of care devices, and there's new technologies with AI, wearables, etc. And there's a lot of effort in the screening for early markers, precursors of disease, population level screening for many disease, and that's all very important. We can still move backward because this is not really prevention. This is just, people already have the disease or they're already on the path of disease that is being detected. So then people think about, oh, I want to prevent anemia. I want to prevent respiratory disease. I want to prevent cardiovascular disease. How do you prevent these diseases? You don't prevent the disease by focusing on one disease, and there are many diseases. If you prevent one disease, you may get another disease, right? So for infectious disease, it's very clear. There are vaccines. You curb the transmission. It's very simple. For non-communicable chronic disease, it's not that clear. We first need to understand and determine modifiable risk factors for specific disease, which has been done for many diseases. It's not 100%, but we know quite a bit. And to address the root causes, including commercial determinants. So you cannot do this for one disease at a time. Some disease may have very specific causes and it may be easy to fix. But really what we need to focus on is to sustain health and wellness throughout the lifespan. And this aligns very well with public health approaches of really having the big picture approach. There are many common modifiable lifestyle risk factors that people can individually do something to improve their health. And this doesn't start when you get your first, bad medical report and say, oh, now I need to eat healthier, now I need to exercise. It's already late. So this has to start very, very early. Even during pregnancy, what the woman does impacts the infant. So tobacco, alcohol, physical inactivity, and unhealthy diet, they've been known for a long time that the four of these by themselves account for 75% of chronic disease. And if we can address this, 75% of chronic disease are addressed. We have new growing concerns with climate change. Clean air is becoming a problem, quality of drinking water. To eat healthy, you need healthy food options. There's also many toxins around. We also need to minimize the use of medications and integrate safe alternatives like Ayush. So importantly, to align the business of health towards prevention and public health goals throughout the lifestyle, really stepping back and thinking about, I was joking when, decades ago when bottled water became common, I said, I need to get in the business of selling air. And now you actually, it's not too far off that people will be paying for clean air. So we need to really, think about businesses, technology, innovations. How can we get clean air for everyone? Even water, everyone's like purifying it in their homes. Many people buy RO and other filters, and that's just not the way things should be. So I will stop here, and then I want to introduce our moderator, Dr. Niyati Parikh. She has come all the way from New York to be with us today for this event. She is the Associate Vice Provost and Professor of Public Health Nutrition at the School of Global Public Health at New York University. She also holds an appointment in the medical school. And importantly, she is a visiting professor at the Bakshi School of Public Health. She has also held leading roles in American Society of Nutrition, and she's done a lot of work in commercial determinants of health. So she's the perfect person to take this on, and she's also been very helpful to me along with Dr. Gadvi in planning this whole event. So over to you.
Thank you so much. As we move to the next part of the program, may I please request the panelists to come on stage and take their seats. Good morning. Thank you for the kind introduction, Dean Joshipura, and to you, Dr. Chandra and the AU team, for this tremendous opportunity to both moderate and contribute to this well-timed topic as India's healthcare sector is poised to grow rapidly in the coming years. On a personal note, this is very special to come back to Ahmedabad because this is the city I was born in. So it is my great pleasure to welcome you. I'm sorry, yes, okay. Wanted to make sure I'm on the right slides. It is my great pleasure to welcome you to the inaugural Ahmedabad Dialogue, The Business of Health. Commercialization of health has rapidly evolved in a modern society. Broadly speaking, this refers to the use of market-driven approaches and profit motives in the healthcare sector, which was traditionally governed by social considerations. Individuals are increasingly treated like consumers, and this shift influences everything from treatment decisions to how health services are delivered. It is well known that large corporations heavily influence consumer behaviors, both positively and negatively. Maybe some examples are the vaccine industry, food industry, tobacco, alcohol industry, to name a few. They use targeted approaches and aggressive marketing techniques to change cultural patterns and norms related to usage. Viewing health through a business lens highlights a mix of advantages and disadvantages. While commercialization of health can drive innovation and lower health costs, it also raises concerns about access, quality, and equity in healthcare, which are questions we will address throughout the day. India is a global hub of pharmaceutical innovation, digital health solutions, and affordable manufacturing. This lends itself to a vibrant environment of growth, jobs, and technological breakthroughs. But the country faces deep disparities in access to care, quality of services, and health outcomes across geography, gender, income, and caste. Now let me provide a quick snapshot of India's health report card. In addition to infectious diseases, the burden of non-communicable diseases is a serious concern as shown in this figure. For instance, high rates of abdominal obesity are observed, which make people more susceptible to heart disease, hypertension, cancers, and even metabolic liver disease. Estimates indicate that India accounts for approximately 60% of the world's heart disease burden, despite being about 20% of the world's population. India is also the diabetes capital of the world, with evidence showing that over 230 million Indians are either diabetic or pre-diabetic. Furthermore, the cost of healthcare in India is rising, so there is a need to carefully examine population-level health and to re-evaluate the business model. Regardless of sector, we all have one goal: a healthier India. We need to refocus our efforts towards the bottom of this pyramid, which is early prevention, rather than focus on treatment and management of disease complications. When we frame the business of health as a health equity issue, what we are really asking is, how can India's growing health economy help close these gaps instead of widening them? Equity here isn't only about who gets care, it's also about where investments go, who gets to shape innovation, and how responsibilities are shared between the public and private sectors. The economic engines driving India's health sector, such as digital platforms, insurance models, pharmaceutical exports, and hospital systems, also influences who gets reached and who gets missed in the community. For the scientific community, today's conversation encourages us to look beyond the research findings themselves and think about how they translate into business models and strategies for population health. For policymakers and leaders, it's about shaping incentives and partnerships that align public benefit and private innovation. Our panel brings together these voices from across the landscape. Government, which develops policies and rolls out large-scale initiatives. The insurance industry that performs risk assessment and expands coverage. And the hospital management industry, where science becomes service and care is delivered. The challenge before us is how to rebalance the system towards healthier outcomes. Today's dialogue will examine the balance between health as a public good and health as an economic enterprise. I invite you to listen, engage, and reflect on how each sector can contribute to a sustainable and evidence-driven business of health. And with this, I would like to introduce our panelists. Dr. Vinod Paul is a globally recognized pediatrician, medical scientist, public health leader, and policymaker who serves as the member in Health, Nutrition, and Education in Niti Aayog, Government of India, where he has played a pivotal role in developing health and nutrition policies, including the Ayushman Bharat, more commonly known as PMJ, Ayushman Arogya Mandir, and Poshan Abhiyan. He served as professor at the Department of Pediatrics, AIIMS, New Delhi, until 2020. And notably, he also served as the chairman of the National Expert Group on Vaccine Administration for COVID-19. Dr. Rashmi Nandargi is the Vice President of Bajaj Alliance General Insurance Company since 2006. She has over 20 years of executive leadership in implementing health underwriting strategy, regulatory compliance, policy management, and product development. As the Vice President, Dr. Nandargi manages the complete product lifecycle with a focus on consumer needs. And finally, we have Dr. Atul Mohan Kochar. He's the Chief Executive Officer of the National Accreditation Board for Hospitals and Healthcare Providers, or NAB, which is India's apex authority for developing and implementing standards related to healthcare quality. Dr. Kochar has over 26 years of experience in clinical care, teaching and research, and also serves as professor and consultant in dermatology at Maulana Azad Medical College and Lok Nayak Hospital in New Delhi. Please note that this is an abbreviated list of accomplishments of the panelists, and the full profiles are published in the online program. Please join me in welcoming our panelists. The panel will start with brief presentations from each speaker, followed by a moderated discussion. Our first presenter is Dr. Vinod Paul, who will share insights from his pioneering leadership at Niti Aayog. It is an honor to have you here. Please, Dr. Paul, the floor is yours.
Let me give these remarks from there. Good morning, Honorable Vice Chancellor, Dean, distinguished faculty, esteemed invitees, my very dear friend, Shri Amarjit Singh Ji. I'm grateful to the leadership of Ahmedabad University and my friend, Shri Manoj Agarwal Ji, for having induced me to come here, which was a very easy decision because I indeed wanted to be a part of such discussions everywhere and anywhere that I can find opportunity for. So first, my deep gratitude and also my compliments for creating a great university, a future-ready university, and also in particular with focus on public health, being led by Madam Joshipura. I'm using this opportunity to make a few remarks to build on what has been stated by Niyati. Firstly, we can start by saying that business of health can be good, and it serves very important purpose. If you look around, I'm talking India context, I don't know the rest of the world, so it's for our country. We are the pharmacy of the world. We are the biggest manufacturer of affordable medicines. We have been instrumental in eradicating or controlling HIV pandemic in the world, not just for our own self, we protected ourselves. We passed on COVID-19 vaccines to 109 countries. The biggest manufacturer of vaccines for children. I can go on and on. So that's one part. It's good business, affordable. And surely, if today our life expectancy has improved from under 30 years at the time of independence to 71 years, this particular business and others that I will exemplify have made a contribution. That's one space. Another space is the good old private practitioner. Whatever little number we had, they served the purpose in small towns, small places. They brought the first elements of specialty care in our country. And Amarjit Ji connected the private sector to reduce maternal mortality in a very innovative way. We can build on that. We can come to those actions later on. Even now, especially in the tertiary space, we have a private sector. We have issues with them, but they're serving a purpose. Under Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana, we have 12,000 of the 30,000 hospitals are in the private sector. We have issues with them. I'll come to that. That's the second part. But it is there, and there are ways to connect and get the best out of them. That's another example. Agriculture is private, by the way. It's private enterprise. If I must be economist in me. I want to
be on, shall we say, hyper academic in that, but in my sense, agriculture is private sector. And they have given us food, survival, and so on and so forth. So just to recognize that business for health, of health, can be great. And there will, I hope, be discussion and opportunity to say how that resource, vibrance, investment, enterprises, jobs, electorate, can be harnessed for public good, which promotes equality and equity. I love your slide. I need to borrow that slide from you. So we have to find ways of doing it, right? And that's where the policy action comes in, societal action comes in, and the leadership pronouncements make a difference because they start to connect us all to find paths. And here, what perhaps I'm reflecting is the Honorable Prime Minister's call on controlling, addressing the problem of obesity. So it changes the discourse and we can come together. So that's the first part. The second part is, yes, we have problems. And just to trigger a few thoughts, let me just say, take examples. And we can take example, I'm looking at Atul Kocharji, standards and so on. So private sector plays hospital system, private hospital corporate system in particular plays games. They escalate cost. It's not easy to afford. They pay the doctors 1 crore, but pay to a nurse 17,000. They over-investigate. And in spite of everything, after 8 o'clock, their critical care drops because then it is the consultants are gone. They don't believe in having a layer of strong residency system, which you have in other nations and in academic institutions, the one that I represent in a way, IAMs and so on. So you have these half-trained physicians coming from certain particular countries running the critical care. So suddenly the level drops. When it is a non-consultant level care, it happens. Other ills to this, and so on. So yes, we have a problem, and that needs to be taken care of, and we play a role through regulation. So it's one example, and I can align with this. Insurance, I'll take another example. Nidhi mentioned that. My team did a little investigation into finding out options in the private insurance which cover as much as the PMJ Ayushman Bharat covers. So 5 lakh per family and everybody included, right? Everybody. And we've made phone calls to, let's say, 10 or 8 insurance companies. What will it cost? What will it cost? It turns out that the typical products, and ma'am, you correct me, but this is what we gathered, officially we gathered, I must say. It starts with 24,000, 28,000, 42,000, 48,000, 64,000, 66,000. These are the quotations we got on conversation. May have changed. Now, bring this in the perspective of what household we are trying to cover. If you look at the distribution of population by quintiles, PMJ covers the bottom 2 quintiles, or a little bit above that. Using the expenditure data, household expenditure survey data, this corresponds to about 15,000 rupees per month per household. So for the sake of academic discussion, 16,000 तक का जो है 15 भी नहीं कहना, 14,000 के cover वाले ये लोग हैं ये. This is the face of the people who are being benefited. 13,000, 14,000, let's say 15,000, maybe a little more now. The next quintile goes up 20%, okay? Every decile actually moves by about 1,000. Let me just build on that. So the next decile is 15,000, let's say, 14 to 15. The next one is 16. The next one is 17. Not very different. Household, 4.5 people, 5 people. It's only after you reach the 80 percentile level, that then the curve starts to move, and the jump happens at 5,000, and then a lot more. The point I'm making is that a person just above PMJ is in the range of about 16, 17,000 per month for a family of 4 to 5 people. Would you give, so 16,000 is my income, 17,000, 18,000 is my income. The insurance product is 30,000, 28,000. Can I give 1 full month of salary for insurance in that kind of a house? So the answer is resounding no. So we want to go behind this and see what is it that we can do to make affordable products. Niti Aayog wrote a report called Insurance or Health Insurance for the Missing Middle. We coined this term missing middle, which has caught the imagination of people. And ever since 2018, when PMJ came, this was our guilt that we could not cover the rest in terms of thinking, policy enablers, trying to find products that can meet the need and the need for a privately funded insurance for this segment, or let's say between the bottom 2 quintiles to the next one and just about the next one. And we haven't really come out with products which can work. And the reason I gave you is the following, that the premium that works out is a hell of a lot, almost double of the monthly expenditure available to the family. How do you do it? So it's a challenge. I stand corrected, but I believe insurance runs on about 25-30% is the cost that insurance companies have to pay for their own running. Okay, so you need 25-30% of what you collect goes into running the system. But that, having said that, we'll come to that. Affordable solutions in that space are not. Now, is it all fair? Is this good business? Can it be explained that we cannot have a product which people can lap up in the middle quintiles? Such a challenge. I'm happy to state that the Insurance Regulatory Agency authority has brought out several reforms, and these have to still trickle down. By the way, and the last point on this is that when these insurances are offered, there's a waiting period. There are exclusions. Now, of course, meant to be no exclusion, but still on paper. Would the insurance company exclude a person with heart transplant? At the moment, well, previously they were. At the moment, not clear. On paper, it should not be done. The point I'm making is that a great business that can provide bridge to healthcare and my out-of-pocket expenditure control through the mechanism of my payments doesn't seem to work even in the middle classes and the people with middle class. Can we do better? We might like to hear this one. The pharma industry, I extol the virtues. But do we know how the pricing happens in pharma? Of course, it's business, fair enough, that you can put a label, this shirt can cost me 500 rupees or 15,000 rupees perhaps, or 10,000 rupees. Using that paradigm, it is also a fact that erythromycin or albendazole can be, let's say, 10 rupees and 100 rupees, 10 times, 8 times. Same product moves in the same company, and it goes then eventually in 2 directions. This erythromycin PP, let's say, and this one is, let's say, SS. This will be branded higher. The price of the same product from the same company is X, and this could be 5X. That happens. What should the society look upon this? They would say, we have private enterprise, we can do it. So you bring in a mechanism of price control. You bring in the focus on generics. So such policy responses that have been listed as a part of the discussion have to be brought in. But then this can also be extreme situation where a drug or medicine which is available is actually reaching the level of not profit making but profiteering. I think from profit to profiteering element that appears on the health-related businesses is what I think we are all concerned about. I think on food there'll be a lot to be spoken, but the same analogy applies to the food industry and so on. But I pause here to say the last point in different sub-theme is to say that we saw how non-communicable diseases are important. We also saw that primary prevention is essential. We would like to discuss what are the interventions that have worked to reduce NCD through public health approach in any population. I like to know where on earth primary prevention has led to reduction in obesity prevalence or diabetes prevalence at population level. I can say this, it has happened for iodine deficiency. I can say it has happened for something else. Non-communicable disease successes at the primary prevention level is an issue. Secondary preventions, perhaps there's some strands to say it works. But since we are talking about business of health, primary health care has no business to do with the businesses, by the way. Primary health care shall be responsibility of the government, of the state, of the people. There is hardly any big ticket idea on private driven primary health care. So let's not forget that India is developing a very strong future ready primary health care now since 2018. And I like to talk more about this. This is where the screening is coming up. This is where a new provider has been brought in. I may get an opportunity to build on that. But the point I'm making is primary healthcare, nobody comes in. We don't see private sector. It doesn't mean that contracting out cannot happen, contracting in cannot happen, supply chains cannot be supported by that. But I want to make a point here in this audience that primary care jo sara hai, which is 80% of our health care or disease care, no, primary care as well, health care is really the business of the state, and we should put our energies behind it, our academic inputs behind it, and strengthen those pathways, because उसमें किसी का और business नहीं है, ये हमें करके दिखाना है, और उसमें health care भी है और prevention भी है. These are my early comments, but I'm looking forward to now learning and allow, hopefully come after other ideas have been thrown on the table. Thank you so very much.
Thank you so much for setting the stage for the conversation today and for just sharing your higher level policy and transforming access and affordability in India. I'll now invite Dr. Rashmi to come and provide her remarks.
Thank you, Dr. Parekh, and I hope I'm audible to the end of the hall. And sorry. I would like to start with congratulating Ahmedabad University and the School of Public Health, Bakshi School of Public Health, for taking this initiative. I think this is a very, very important and a very, very critical discussion that needs to happen, and this is the time that, this is already high time that we need to discuss, understand what is happening. Thank you. To discuss, understand, and what is happening across various aspects, because healthcare covers various aspects, the providers, the payers, and the policymakers, and obviously the consumer or the customer being at the center of the stage. And we all need to understand what are the challenges and how we need to bridge the challenges and what is it that we can do. So I'll spend some time to discuss on the topic that is being discussed today, the non-communicable diseases. from the health insurance angle and how we look at it, what is it that we are doing at it as an industry to take care of this. So definitely there is a lot of talk, or there are a lot of initiatives that are being taken, lot of discussion, and we come across lot of cases for non-communicable diseases. We hear a lot of recently we saw many celebrities being diagnosed with cardiovascular conditions. Not only celebrities, we saw cardiologists are also being diagnosed, and this is definitely impacting us with a very, very significant impact to us, having a very significant impact on our lifestyle. So this has brought a demographic change in India, and this is going to definitely reshape the health insurance, the way we look at health insurance, the way we have processed health insurance and administered health insurance till date. And this is an inflection point. We are sitting at an inflection point where we are looking at how things have been. So typically from an health insurance angle, also as a consumer of healthcare, prior to a decade ago, health system was very, very simple. It was very episodic. People used to fall sick, take treatment, get better, and then go back to work. And it was as easy and as simple. But nowadays we see that a lot of complications are coming up. Lot of diseases have come up, especially associated with the non-communicable diseases. So it's no more a episodic event. It definitely is something that needs to be addressed and looked upon in a continuous way. So as we all saw and heard, that almost 65 to 70% of the conditions are arising out of the non-communicable diseases, and this is a very, very alarming situation for all of us. So why this is going to impact us, and how this is impacting the morbidity of the population. One, these conditions are long-standing, and they go on for decades, and some of them go on throughout the life. It has to be managed throughout. Second is, there is a continuous management administration of drugs, which has a very, very compounding impact on the population. They have to take drugs throughout their life to manage and maintain the health. Third is, even though the health is maintained and managed, there is an increasing probability of developing conditions. A person having diabetes, even though it's maintained, may land up into complications over a period of time, looking at the disease, how it progresses. And the most worrying part for us is the earlier onset for the Indian population. I think Dr. Parekh agrees that in India, the disease onset is almost a decade prior what we see in the Western counterpart. So all these things have impacted healthcare to a large extent, and it has a very direct impact on health insurance. Like as I said, as health insurance industry, we had the products were designed with the kind of episodic approach of looking at the health status at the time of onboarding, what happens after that. So now we need to, the complete geometry of health insurance, health pricing, health product needs to be addressed and reviewed further. So we need to move ahead from episodic to a lifetime trajectory of health insurance. So how do we, the industry is already on the path, but yes, a lot needs to be done on this aspect as an industry. So how do we, typically in health insurance, at the time of onboarding, we call it as underwriting. We used to look at the health status. A person is applied for a health insurance, maybe 40, 45 is the average age that people think seriously about health insurance. We see what is the health status. And to cite a small challenge here from health insurance perspective, the data that we get to understand the health or to understand the risk is very, very minimal. We don't get extensive data about the lifestyle, about the family history. There is a lot of resistance, and also there are other aspects of ease of doing business which impacts that, okay, we have to assess the risk and take the decision basis on very few 3 or 4 parameters. So basis on that, the decision is taken basis on the existing health status. What is the health status of the person? So now we need to see a long-term trajectory and not just the health status, what is there today, how the health is going to change, what is the person, what are the conditions, what is the age, the family history, and all the biometrics, and see what is going to be the trajectory of this particular individual whom we are going to underwrite. So that is something that needs to be developed, which is, as I said, underway, but definitely this needs a lot of support, awareness from the common person, giving that kind of importance to health insurance. But still, we see that health insurance is considered that, okay, as a financing option. So we need to rethink about it and take it as a risk management tool for our health as well as finance. Unless we have a strong health insurance, our finances are going to go for a toss, and definitely healthcare, as rightly pointed out by Dr. Joshipura, the better the health insurance, the more the care, the better the care. The people can go for higher treatments, advanced treatments, and the outcomes would be very, very good. So all these aspects definitely are going to impact. So as I said, at the time of onboarding, we look at the health status, and traditionally the practices are like, okay, we accept, or we accept with certain exclusions. We say, okay, these particular things we are not going to cover for 2 years, 3 years, 4 years. Or we say, okay, there will be a particular percentage of loading because of the substandard health, or if it is a extremely adverse case, people buying health insurance after a lot of diseases are contracted, then the insurance company probably used to say that, okay, we may not underwrite this risk. But now the times have changed. We cannot take this stance, as the healthcare conditions, the non-communicable diseases, almost we see 70% of the population, almost 1 in 3 people definitely would be having one or the other conditions and would develop the other conditions. So we cannot stay away from this and say, okay, I want only healthy lives. So we need to, we are in the stage of evolving and seeing how can we then make the underwriting policy more adaptable so that we cover all these things. And then we also not only cover, but we also need to design the policies which are in line with the changing health dynamics that we see today. So because health insurance and the non-communicable diseases, as I said, it's not an episodic event, it's a lifetime event, and health insurance is also required for the lifetime. So the association is going to be lifetime. So we need to see how we engage with the customer. So that is one more aspect that today we underwrite, we onboard the customer, and then the engagement is very, very minimal. Though there are a lot of initiatives, there are a lot of policies which are being brought by the insurance companies to increase the engagement, but yes, there has to be efforts which needs to be taken from all the healthcare payers, providers, as well as the consumers to see that the engagement is there and how this is going to help all of us in the journey of health insurance. So traditionally in health insurance we see like health, maybe a decade ago or 10 years ago, health was seen as a very, very sensitive topic. Like, okay, this is a liability, and aging population, person coming with diseases definitely is not going to be a good risk. But the lens through which the insurance companies are looking at lives has changed, because we cannot stay away from what's happening in the population, in the society. So now we are seeing how we can build the engagement platforms, how we can build nudges so that we are guiding the customers, consumers for nutritional assessment, monitoring of health, evaluation of parameters, what are the outcomes, and how can we handhold them to manage the health and not just pay the claims for hospitalizations. So that aspect definitely is there and is being worked out. But along with that, another aspect that plays is the premium aspect. So India being a very, very price-sensitive country, the first thing when we go to person for health insurance, when the marketing team approaches, the first thing is, okay, what's the premium? We also had in the earlier that the premiums are very high, how we look at it. So the premiums are decided basis on two factors. One is what is the prevalence of diseases, how many people are falling ill, what kind of population that we are onboarding, how they are managing their health. And second is on the hospital side, what is the expenses that the hospitals are charging for a population which is insured, which is non-insured, does it differ, how the financing or the billing part is taken care of. So all these aspects put together are then analyzed from the actuarial angle, and then the pricing is decided. So now this used to be like, okay, what is the past experience, what is the current health status, basis on that the pricing was given. Now only these things will not help. Now we need to look at, as I said, the trajectory over the next 10, 20, 30, 40 years. If a person is taking policy at 30 years or 40 years, what is going to be the healthcare expense over the next 40 years? How can we make it more affordable? How can we bring in the nudges so that people can manage health and we become health partners for managing health and not just paying claims when there is a hospitalization? So all these aspects are taken into consideration when the actuary is pricing the model or when the actuary is working on the pricing model. And along with that, there is also aspect of incentivizing the customers when they are taking good care of their health. And also it never comes that, okay, all the insured people are taking care of their health at the same aspect or at the same level. Some people are very, very careful, they are extremely fit and they are taking good care of their health, they are monitoring their weight, they are doing their health tests, and they are also visiting the doctors. At the same time, we also have a set of population who always feel that, okay, nothing is going to happen to me because all the non-communicable diseases are very silent. They don't have any signs, symptoms unless something very large claim comes for either the heart or the brain or there is some kidney damage. So until and unless these things come, people feel I'm healthy, I'm doing good. So why do I need to take so many interventions to take care of health? So even though we see that the mindset is changing, but we see there is a spectrum of people who are at this side and this side. So the policies are being designed or customized basis on the lifestyle, taking into consideration all these aspects. What is the person doing? How is the person taking care of health? Is a person so health-centric or health-conscious that the person is going for a marathon? We have built incentives for that. If a person is consistently every 6 months, every 12 months doing his health tests and then submitting the reports, reviewing the reports with the physician, so the incentives are built to take care of these things also. And if there are any conditions which are seen, so we also have since last 3 years inbuilt OPD so that the treatment can be started at a very, very primary level and not wait for any hospitalization to happen. So yes, all these aspects are being taken into consideration to take care of the non-communicable diseases, and the endeavor of the insurance companies is to become health partners and not just finance the hospitalization events. Yes, thank you.
Thank you very much for your unique perspective at the intersection of risk assessment, data analytics, and health behavior economics. It's really crucial for us to understand how health equity and population, towards health equity and population health. So this is a perfect segue actually for our next speaker, because insurance is very interconnected with the hospital system. I invite Dr. Kochar to discuss the role of NAB in shaping population health. So over to you.
How long it takes. But it's indeed a great privilege, and I would like to use this opportunity very briefly to place before you certain facts. One, there are 197, 198 countries in the world. of which only about 44 have their own structured healthcare standards. And India occupies a place of pride there. So I think it's a great moment of joy and privilege for us. And that structured standards have been led by NABH. So this is an opportunity to place before you who we are, what we do. NABH is just one of the autonomous boards under the Quality Council of India umbrella. We are a 27-year-old quality. QCI was formed by Government of India along with all industry bodies, FICCI, ASOCHAM, CII, coming together with a single line vision of creating an ecosystem for quality, which means wherever there's a need felt for drafting of standards, whether it's education, whether it's technology or any other thing, they lean on QCI for taking it forward. So today we work very actively with 56 ministries, whole lot of international bodies, state governments, central government of course, and we are working on just this wide spectrum of projects from the assessment of all DRDO vendors, for example, which build satellites, to the Swachh Sarvekshan every year, year on year, for past 8 years now, to the quality of coal in the countries, to the quality of exports of fisheries. I'm just giving you a wide spectrum, but there are 56 and whole lot of confidential projects, everything. So we are the healthcare vertical, and we draft and assess against our own standards. So probably you've heard of ISO, which is been authorized to our sister board called NABL. Medical labs is a very small part of that, but there are a whole lot of testing labs, calibrating labs. So thousands of labs are covered under NABL. We take care of hospitals. We completed 20 years on June just gone by. And today we are partnering with about 26,000 hospitals in the country, and we have presence in 8 more countries as far as Philippines, all the SAARC countries, probably except Pakistan. So we have that presence. So these standards are all related to patient safety and healthcare quality. Since we are a board, we are actively collaborating with insurance, madam. IRDA is a member. GIC, all 32 health insurance companies, we work very actively, and we hope that all those. So another fact is that we are a federal structure given by the Constitution, our country. So there are 28 states and 8 union territories, and each of them big enough to be bigger than a European country or a nation, for example. So the problems of complex, the healthcare vertical is very complex. As Professor Paul very rightly pointed out, that primary care is the responsibility of the government, no doubt. But still it's a big, big world out there, and it's a very big and diverse country out there. So that's another fact. And another thing is that during COVID, like 5-6 years back, it was a great mirror which was shown to everyone. We realized that there is no optimum solution which we can label as the solution for healthcare. Even the countries which we look up to for their development, for their infra, for their world-class facilities, they were all left reeling with lakhs and millions of deaths, what to speak about the morbidity. So there's no one solution fits all, and somehow it is left to each country to develop something which is indigenous, which is something workable. And that's why these brainstormings like this, these dialogues like these, bringing all stakeholders together, having a series of workshops to dwell upon them, and having someone speak about the hitherto unspeakable issues like non-communicable diseases, because one, they are not measurable as such in the truest sense. One, the outcomes are not visible for the cohorts in a very short term. And one, about primary care, which of course being the responsibility of the government, there's no finance in it. There's no short-term profit or long-term gain in it. So that's why such dialogues are very important. Another fact before you is that we have a very robust system of alternative medicine, which we call, or Indian System of Medicine, ISM. Many of you may not be aware that there are 564 Ayurveda medical colleges, or 262 homeopathic medical colleges, and a large number of Unani, a large number of Siddha, and also Sova Rigpa, yoga and naturopathy. So this is untapped wealth. If we were to include this into our policies, into the healthcare delivery integrated model, then probably our ratios of the UN sponsored, the WHO given ratios, they can all be amalgamated together, and we probably will have a much favorable ratio of provider versus providing. With all the current gaps which are there, so probably that's another reason to dwell upon in the panel. Another fact before you is that with all these, so probably when we were left reeling with COVID, I think we emerged very better, because we had, we were one structured health, because of the structured NABH health standard, and it was a fact that all those hospitals, probably not 26,000 then, but 20,000 still, they could cope with the changing dynamics of the SOPs, which were changing from minute to minute or hour to hour. They could cope better, and there was less morbidity and mortality. So that's another thing which probably we need to consider. Another fact is that India is considered the cradle of digital revolution. I mean, it's our people who are funding, or who are spearheading the revolution, whether it's OpenAI or anything abroad. So this technology has to be used to bridge this wide gap of provider versus providee, and integration of the Indian system of medicine with the modern allopathic system can come together. What China did probably years back in their barefoot doctors, somehow something public health needs to cognizance of those people also. And NABH probably, not probably, we are the only accreditation body in the world to have, since 2008, a system of quality, evidence-based medicine, and accreditation of Ayush facilities also. And a whole lot of what I just mentioned are already accredited, instituted, following SOPs. So these are just some open thoughts, ma'am, but I'll leave you with the last line, that we are in the land of Gandhiji, and behind every cover of NCERT book we used to read when we were in school, they're the Gandhi's talisman, they call it. That whenever you are crafting a policy, think of the poorest of the poor, and then you can't go wrong. I mean, it's not verbatim, but it's something. So, Dr. Paul, madam, you also spoke about policies being crafted. So while we speak about policies, and we have policies, we are a structured nation. In the world of accreditation, we are 5th in the world, worldwide. I mean, of all the 170 countries which participate, that's no mean achievement. But whenever we craft a policy, I believe those policies should be catered and geared to the last in the line. Only then we can expect to be a Viksit Bharat much before time. So we look forward to the panel. Thank you.
Thank you for sharing on the role of NAB and its vision to support a resilient, patient-focused, future-ready healthcare system. Taken together through these presentations, we have come to better understand the opportunity for various stakeholders and the operational realities of India's health reforms. I look forward to a robust discussion in the next part of our program, and for about 35 minutes, we'll have a moderated discussion and then open the floor for question and answers with the audience. I will also, my role is also to keep time, so we could all be seated and we can do the questions from here. So, thank you. All right. So my first question is to you, Dr. Paul. And you've mentioned some of this, but how do current government policy and financial incentives shape the kind of health outcomes? We had begun to talk a little bit about the prevention side of things. At this point, we have more pre-diabetics than diabetics. So you know that that population, as an example, is needed to be managed. So could you talk a little bit more in depth about this, please?
Focusing now on MCDs.
Yes, please.
I think in the space of MCDs, the current way to handle?
Yes, yeah, please do. Okay. Should I try to use that? I could try.
Thank you. Is that okay?
Yes, I'm going to try to use.
So in the space of NCDs, let me cite a few examples where very definitive action has happened, and then we'll come to the specific one that you are referring, pre-diabetes and diabetes. So let's start with what we have done in the past for tobacco control. We have done well. We raised taxes. We have a public opinion change over a period of time. It's for quite some time now, it's not super fashionable. It's not that cool to be smoking. And you seem to hide your smoking habits. So it has happened over a time. If I go back to my school days and childhood, it was a fashion. It was a prestige. My classmates were, we were seen to be stupid, like less cool. So you can see that the change has happened. Taxation, public action, and so on. So it has built over a period of time. Another one which the nation, in a way, averted that tragedy, I would say, in the same space, was nipping in the bud of the e-cigarette ingress into our country. Where I think going back to 2017, 2018, when e-cigarettes were being touted as a harm reduction strategy and vaping, and it started to become a discourse very early, very early stage. The decision was taken, BANED, banned, and that took care of a lot of trouble. So I think there is a power of doing things in time before the monster is of a unmanageable size. So e-cigarette is an interesting example we can cite in this particular space. But I'm finding it difficult to cite other examples. If others are aware of it, we can talk. But we should keep in mind that in the space of obesity and diabetes and hypertension, currently the emphasis is on secondary prevention. Joshipura ma'am showed us that paradigm, that it's not prevention, the first level prevention, but in my learning it's called secondary prevention, that you detecting early and acting early. So currently, bulk of what we have thought would work is in the space of jaldi pakdo aur uske baad usko kuch karo. But it also comes from the fact that strategies that work on population level to change those determinants, personal determinants, physical activity, food, as well as commercial determinants, as well as perhaps by extension environmental determinants, we as academics have not offered those strategies which work on scale in public health. I'd like to know in which geography have we seen that 1 million population shows after that intervention, whatever that be, reduces the prevalence of obesity and pre-diabetes by a certain fraction. It hasn't happened. And that's, I think, one challenge. And it has hell of a lot to do with behavior. And behavior changes, there's a science behind behavior change, but how to harness that on scale is an issue. I want to put a caveat here that individual level, the same advice would work. Hey, go for a little more physical activity, change food. I'm a doctor, I interact with 5 patients, 10 patients. Maybe 1/3 of them would actually show a change. So in individual practice, smoking भी बंद कर देता है, कोई खाना भी थोड़ा ठीक कर लेता है, एक्ट भी कर देते हैं, लोग वजन भी कम कर लेते हैं, HbA1c भी कम हो जाता है, compliance भी हो जाती है, तो primary, secondary सब कुछ हो जाता है. Individual. What is it that we can do to reduce these risk factors and the outcome thereof at population level is the biggest challenge. And I like us to think about it because we talk about it, but we offer very little in terms of how it has to be done on scale. How do I reduce salt intake at population level? By changing habits. We haven't done it. How do we reduce fat intake on scale? We haven't done it. Let me touch on these two, because this is where, the two good examples. Our oil intake in the 60s was 3 kilos per capita per annum. By 2000, 2004, this is NIN data, my NIN colleague is here, it reached about 11 kilos, 10 kilos. And according to the latest guidelines of ICMR NIN, it's a 9 kilo per capita per annum is good, it's okay, optimum. Today, we are at 19 kilos as a nation. कैसे बदलेंगे? And this trend is rising. इसको कैसे बदलेंगे? प्रधानमंत्री जी ने अपने तरीके से कहा कि 10% आप कम खाइए, 1 किलो कम करो साल भर में. एक हुआ, थोड़ी अवेयरनेस बढ़ी. Change scale पे कैसे आएगा? Salt. We all are on average taking double the salt that we should be eating. We know it for the last, at least, from Dr. Srinath Reddy's work, I know it since mid-90s. बदलता नहीं. So सबसे बड़ा challenge है मैं कहूँ. Academia is sitting here, thinkers are sitting here. It's a great debate. Can we demonstrate a change on scale? And I'm dying to hear that, because having been associated with comprehensive primary health care, health and wellness center, Ayushman Arogya Mandir, this theme, it is my pain that on the primary side, how do we work? We talk about physical activity, yoga, meditation, food, Ayush, Ahar, Indian food, good food. लेकिन इसको पैकेज करके स्केल पे कैसे लेके जाना है, वो हम नहीं कर पाए हैं. Behavior change on scale is to be seen. I just want to mention here that थोड़ा थोड़ा होता है. एक और example देते हैं. Breastfeeding. There was a time when, going back to 90s, where bottle feeding was a fashion, late 80s. धीरे 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 over a period of time, policy makers, people like Kamajit ji, pediatricians and so on, breastfeeding improve हुआ, काफ़ी आ गया. Optimum नहीं है, लेकिन धीरे 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 कुछ होता है. So there is hope in this space, but we still have to wait for action in this area. And that. Second point, can we do much better on secondary prevention? The answer is resounding yes. Screening, annual checkup of every Indian above a certain age. Today we are saying 30 years. Possible. कितना कर पा रहे हैं? Perhaps 50%, perhaps 30%. But screening should not end with screening alone. The next action pathways still are not deep into the system, which means I confirm my blood pressure, one reading at by the community health officer, abnormal BP, I confirm it, I give advice, I also offer a treatment. Treatment is to be continued. For hypertension, after beyond a certain stage, for most it will be a lifelong. रोज गोली खानी है, करके दिखाओ. The proof of the pudding is when in that Ayushman Arogya Mandir area, 5,000 population, if today above 30, the prevalence of hypertension is 30%, 2 years later when we go there, is it 20% or not? People with abnormal blood pressure, whether primary protection or through treatment, I'm protected. If I take a little medicine, I'm protected, right? So primary नहीं होगा तो secondary prevention, huge space. We are committed to annual checkup for blood sugar for every citizen of India above 30 years of age every year. Future past will not develop. So I give you a challenge here. In fact, I would say that's a very important message from me in this audience. हम क्या अपनी प्राइमरी हेल्थ केयर आयुष्मान आरोग्य के थ्रू जो कॉम्प्रिहेंसिव प्राइमरी हेल्थ केयर चल रही है उसको फुली ऑपरेशनल करके कहीं दिखा सकते हैं? एक ज़िले में दिखाएं, सारे 12 पैकेजेस काम कर रहे हैं, रोज दवाई जा रही है, रिमाइंडर जा रहा है, इंटेंट यही है. इंडिया इज बिल्डिंग द फ्यूचर रेडी, द बिगेस्ट प्राइमरी हेल्थ केयर पैराडाइम इन द वर्ल्ड एवर ऑन दिस प्लैनेट. लेकिन वी आर नॉट ऑप्टिमम. स्क्रीनिंग हो गई, अगला नहीं हुआ. कैंसर स्क्रीनिंग ब्रेस्ट का मिल गया, अगला स्टेप ट्रीटमेंट, वापस आओ ट्रीटमेंट, फॉलो अप. This is a challenge. So currently the structure has been placed. New 125 lakh CHOs have been put in place, SOPs have been done, action. And I want to give a challenge that academia should show it. In my world of child health, we were asked to demonstrate reduction in mortality, nothing less, reduction in mortality due to ORS or zinc in research settings on scale before it became national policy. पहले करके दिखाओ, ये वैक्सीन काम करता है तब आता था, जिंक जब काम करता था तब प्रोग्राम में जाता था. नॉन कम्युनिकेबल डिजीज में ऐसी रिसर्च नहीं हुई. So then what did we do? We used the, shall we say, academic paradigm and say screening would work, screening डाल दिए. लेकिन अभी उसको उस लेवल पे हम लोग, how part is not known, implementation is not known. So my request is that we look into it. Last bit I want to bring to your kind attention is children. Children between the age of 10 to 19. 10% of them are pre-diabetic. We need to catch them there. What is our school health program? Please, I want people to speak about this. This conversation should resound for adolescents. And where are the adolescents? There are the older than 5-year children. In schools. School should be a place for health, lifestyle, positive mental health. We are not going in that direction. School has to be an action area. That's where 20% of India's population is. And that is the primary care that we should do it. लेकिन हमारे पास वो strategies हैं क्या जो कि mindset change करें? वो हम लोगों ने craft करनी है. I'll pause here. Thank you.
Thank you so much. I'm going to keep the conversation flowing and invite the other speakers to chime in on the prevention side as well. And if you could keep your remarks brief, either a reaction or talking a little bit about what your sectors are doing with this. I mean, so many questions come to mind, but maybe we can start with this one. And to keep it a little bit more interactive, I might change my strategy and open the questions to the audience and intersperse mine. So please keep some questions ready. It's coming next to you. Yeah.
So thank you, Dr. Naiti. Again, I would like to reiterate, see, prevention, 1 rupee spent on prevention is equivalent to probably 10 rupees spent on therapy and all those follow-ups.
Okay.
Is this working, please? Right? Okay, thank you. So prevention is something, and so what I will again come back to highlight, I'm not talking shop, but our standards have been promoting prevention at a major level for past 15 years. So whenever we assess a hospital, we expect that the doctors there, at least in small or big manner, address the prevention issues also. And these are challenges which very rightly pointed out, that there are multiple issues. Healthcare world is very complex. We speak about mental health, we speak about food intake, we speak about protein intake. We are having a workshop, right, on prevention, obesogenic, etc. And I think what we need more of is leading from the front. We just had saffron tea at a world-class facility. And this is what India needs more of. We need not only a focus on cleanliness and all that thing, but also menu planning. So I was told there is no fried stuff there despite a huge demand for samosas. So while something is easily available, and street food, etc., it takes a very conscious decision to implement what Professor Paul just pointed out. You just cannot have 2 rounds of gulab jamuns or bhaturas and then go on and expect a subsidy from the state. So, and catch them young. Not only school, this 10 to 19. You would agree that in the US, pediatricians deal up to 21. Right? In India, we cap it at 12 years. I mean, 12 years, beyond that, they refer you to a child to an internist. It's just not fair, right? So maybe those policy changes, because they are still maybe bigger kids, but they are still kids. So you have to not only catch them young, but to bring about a cultural and behavioral change in the outset, in their mindset. It's a constant thing. Any behavioral change takes about 20 to 30 years. And this is probably what the young India is going through.
So may I actually add to that? You know, I think Dr. Nandargi, you said most people start thinking about health insurance at the age of 45. From the angle of prevention, can you discuss some of those aspects to catch them young?
Yeah, I'm audible? Yeah. Okay. So as Dr. Paul rightly touched upon the point that definitely the question of taking care of health or being aware that, okay, am I falling in that category of pre-diabetes, what is the problem? Before that, I think the awareness is very important. Where do we start? How do we start, and how do we come to know, okay, what do I need to understand about food, about life, and these things? I think definitely the stepping stone should be at school level, wherein health care subject should be introduced. We have the physical education. I think similarly education of food. Very simple, for example, what comes to my mind, I can relate this at my personal level. When my daughter used to have something new or something which she used to like a lot, she used to ask, does this fall under a healthy category or this is junk food? So creating awareness, having probably books wherein pictorial representation of what is healthy, what is unhealthy, what is green, what is fiber. So these kind of very small things, I think then it becomes as a part of your life. You learn, you see, then it is involuntary, because now there is a lot of voluntary effort that we need to take. Okay, I need to go, I do my health checkup, I need to get up, go for a walk, I have to see what I am eating, I send it to my nutritionist, and then they will guide. So if we imbibe this in the cultural and education system, I think then it becomes involuntary, and then we can definitely look at very good reforms, and at least we start now, and those children becoming adults, we can expect a good.
But from the insurance point of view, is there anything that you have in modern?
From the insurance point of view, we have started giving the preventive health checkups included in the health insurance policies, annual preventive health checkups. We monitor those aspects, and we are also extending programs to manage the health wherever the preventive health checkup parameters are not good. We are also trying to work with some of the partners to see how can we handhold people wherein people are already diagnosed with conditions. How can we handhold them to bring down the conditions or manage the conditions so that the progression doesn't happen to a large extent. And yes, we are definitely incentivizing people who are taking care, who are aware of their health.
Yeah.
And policies are also being customized to that extent. Yeah.
So I'm going to ask one more question and open to audience questions, and that's about AI. I think everybody has mentioned it in some way. We know how great, am I audible now? Yeah. How great AI can be, but again, if it's not adopted evenly across the geography of India, it can actually increase disparities rather than bring the gaps, close the gaps. And I think, Dr. Kochhar, you mentioned something about it. I know there is the Vision 2035 that talks about the digitization of health and collecting data, using that evidence towards AI. So I would really like a small dialogue, and all three of you feel free to contribute to the future, which is AI and health. And you could go first.
One a very short comment on the insurance. I think India is the only country with the biggest ABPMJ program now. It covers more than 90 CR people, and these are the poorest of the poor. They are the resource challenge settings, and they are the biggest beneficiary, which is already enrolled. So we are a big country, no doubt, but 2/3 of the population is already covered under that scheme, which itself is a great go. Beyond the federal structure, this is the central push, and it's taking shape very well. So the reasons to be very optimistic. The other fact on insurance is that Dr. Devi Shetty of Narayana Health, he proposed a program that by paying 1 rupee per day, he could insure, and he has an insurance company, the plan is already in motion, every family for life, if they pay 1 rupee a day, which is 30 rupees. So probably that's also something which needs to be explored, and products could be devised. The third fact probably is that insurance companies, no doubt, where the common people's claims are getting rejected, the profits of the insurance companies are out there to see. So that also something needs a very huge deliberation, something. But coming to AI, AI is a very positive thing. AI for a country like India is going to have wider ramification in the positive sense. But it has to be handled well, and we have always conceptualized and learned. So Indians have been very quick to latch on to newer technology. And probably this is going to be the biggest push now, which will help in taking technology to the grassroots.
Could you talk a little bit more about that, Dr. Paul, from the government perspective?
AI is seen as a very major disruptor, a technology which is transformative, revolutionary, making impact increasingly every day. Neeti did a paper which demonstrates how critical creation, adoption, and adoption of AI is for Viksit Bharat goals, for our productivity, for our leadership. And one point that emerges is that India should not only be the biggest user of AI as we move forward, given our population and the size of our nation, but the biggest creator. And that's our destiny. That's the need for the nation. The second part is that the nations which will make the best use of this new technology, going with the past examples of such big disruption, the fact also is for them that those who adopt will perhaps harness the potential better and more quickly. Creation is important in any case because we should be able to capitalize on it. But adoption is equally and very, very important. And for small nations, with adoption, they can go ahead and do a Finland where Nokia was ruling because they adopted quickly. So it's so critical, fundamentally critical, that if we don't master AI, our own journey, our prosperity is in peril. That's number one. Number two, health and AI. Clearly, 2-3 sectors are seen to be the most important, at least in the current visualization. Health and agriculture, right, pop up on the top of it. And AI for health, I like us, that we have a great scope to work with. We have an ecosystem on which we can create these applications and products for the world and so on. But I want to emphasize 2 things. One, that AI should not only be seen as, as a tool largely in the space of clinical medicine. Because today when you talk about AI, the example that you'll hear in pharm circles is how it can diagnose X-ray for a certain condition. And of course, there are some people wrongly And in fact, irresponsibly would state, ये सब कुछ diagnose कर देता है, सब कुछ तो कर ही नहीं सकता. Chest X-ray has, pleura, it has bone, it has heart, it has pericardium. So they don't understand. जब जो लोग ये कहते हैं, by the way, I want to educate you a little bit on this, सब कुछ कर देता है, X-ray diagnose कर, no. TB के लिए करता है, नहीं करता. Cancer के लिए करता है, नहीं करता. Pleural effusion, these are different entities. There are 1,000 disorders in the chest. And no AI with whatever can claim that they can, someday it will happen. So थोड़ा सा hype को थोड़ा होना चाहिए. But it should not be only seen in the space of clinical medicine, X-ray being one example, path diagnosis being another one, physician assistant, that while we are talking, things are being generated, reports are being written. Now this is one space. I want to highlight 3 other areas where discourse on AI and health should be augmented. One, in primary health care. The things that we are talking, it's a space by itself. How, and you have the tools of AI-laden tools which are making a difference, is familiar, and we can do more on this. And in that regard, how can I use AI for the comprehensive primary healthcare system in the hands of the team at the primary healthcare level, grassroots workers, the Anganwadi for nutrition, PHC doctor, and ambulance driver, trauma, this, that. So primary healthcare and that part. The third, where we still need to think in a big way, is public health, epidemiology, disease forecasting, surveillance, public health action, precision public health, uski koi baat hi nahi kar rahe. And public health being peculiar to every nation, if we don't devise our tools, AI-driven tools, who will give us these tools? We haven't been seen in COVID that nobody comes to our rescue for pandemic preparedness. For example, as a part of that public health preparedness using AI, we only have to do it. I like this discourse to go out of this room to the technology people. Think about it, it's raw. And I urge, in fact, your team here to please pick on this idea. I have an opportunity to talk this one, because the IITs of the world are on the other spaces, by the way. And they are finding solutions for every sector and so on. So I like us to think public health, contextualize Indian public health, primary care, wahan pe AI ka kya hoga, including biosecurity angle, pandemic preparedness, and so on and so forth. We need tools in that. The fourth space, primary care, clinical, public health, is the health system space for AI. Now, our health system is different from the health system elsewhere. Yes, hospitals may have commonality. Maybe 40% is common. But our own health system, supply chains, program management, controlling NCDs, referral systems, right? We need tools for that. So I want to urge you that please enlarge the debate on AI, deepen it for primary healthcare on our context, our youth, our children, our elderly care, by the way, a big one, where AI can be helpful, wearables, preventing fall, etc. Then classical clinical care. सब उसी की बात कर रहे हैं. ये cancer diagnose करता है, ये diagnose. And there, also I want to add another thing in this August audience. Validation of AI tools doesn't happen. Or it happens on 23 patients or 510 patients. No. Suppose the AI tools misses my breast cancer and says you are okay. And they say, yeah, 90% sensitivity, so 10% it'll miss. Who is going to pay the cost? I'm only come for new checkup 1 year from now. By that time, my cancer is this big. So, ये hype है बहुत ज़्यादा. Validated AI tools are minuscule. You can count them on fingers. So that's one space, primary health, clinical, health system, and public health. So that space we should capture, and we need it for our future health. Definitely we need to master, and we have potential. I like this to be picked up in this manner, and I hope this discussion will serve the purpose. Atul, we should think of doing this more and widen discussion, CII and so on. Much more should happen there.
Thank you.
And in India, Dr. Neti,
Sure,
just to add, sir, India is very few of the countries which have a India AI mission with the direct oversight of the highest leadership. And there's so much work in collation, everything which is going on in the AI field, that's become the central node. So public health, of course, is a very important vertical, but all that's happening in AI in India is today monitored, controlled, collated, and maybe will soon be, vetted before and validated before it's released. So it has, just to add to.
Thank you. And I'm also particularly thrilled that you said public health is front and center. So that's great news for us. I'd like to have the audience please ask questions and tell us what sector you're from. We have practitioners, students, academics, and just the public at large. So yes, you have a mic there. And please let us know if you've directed the question to a particular speaker as well.
Hello, ma'am, and hello,
Cannot
panel
hear
members.
you, it's not.
Hello, am I audible now?
Yeah.
I'm Durgesh Modi. I'm a practicing physician and a PhD student at Bagchi School of Public Health. One of my question is, you said, sir, that PM Pradhan Mantri Jan Arogya Yojana covers about 90 crores of the Indian population. But it means that it should ideally cover. Is there any data that, so 90 crore people is about 20 crore families. Is there any data that how many of these 20 crore families have availed the Pradhan Mantri Jan Arogya Yojana in past 5 years? And other question is, an old data said that for OPD and IPD both, government covers about 30 to 35% of both OPD and IPD, and rest is taken care by private sector. And you said, sir, Paul sir, that private sector has a space. So what is Niti Ayog's vision, whether to maintain this maintain this number, or which way the Niti Ayog is advising government to go, whether to maintain this percentage or to increase public sector or to increase private sector?
Okay, I think that was.
Niti has to help because the acoustics are not
there were
good
two
here.
separate questions,
Yeah.
and the first one, we'll take one from each person
Please,
first,
please.
is really about the coverage and uptake of Niti Ayog, of PMJ, correct? That was the question. Why is it only the proportion of people, why is the uptake what it is right now?
You mean
90%.
uptake or the eligibility criteria? There are two things. Why the
Uptake.
eligibility is limited, right? Why is it not covering everybody?
No, sir. So eligibility is 90 crores. That is about 20 crores families that I get. What is the uptake? How
What is
many
the
of
uptake?
those
And why is it
20
low?
crore families have
Uptake
availed?
means utilization of the scheme?
Yes.
All right, okay. So, PMJ intends to cover 12 crore, 10.74 crore families, then senior more than 70, everybody is covering. The target becomes, or eligible population is 60 crore. States have added additional population, including this very important state, where without central government's assistance, they cover fully their own, and this adds another 8 crore or so. So it goes to, let's say, 65 crore. So 65, 70 crore is the ambit today, technical ambit of the PMJ. And by the way, that would be 45, 48% or close to 50%. So पहला खुश होना चाहिए कि देश ने लगभग आधी पॉपुलेशन को ये हेल्थ इंश्योरेंस दे रखा है. And you can go and get it, right?
Yeah.
43 crore को कार्ड भी मिल गए हैं. कार्ड सबके होने चाहिए. We all have to contribute to that direction. So 43 crore तो identified हैं, उनके पास कार्ड भी है. बाकियों पे नहीं है. मैं ऐसे इसमें बता रहा हूँ कि 60 है, लेकिन 43 तो बिल्कुल identified हैं. और हर every family which is entitled more or less now has at least one member with a card, which means the others are basically being passive, not making the card. But there is that footprint. So this is the first achievement. Every day, okay, 60,000 admissions are covered under PMJ. Total in a year, it is 2 crore now, which is 4 Norways. Every 3 months, entire Norway gets healthcare for 1900 plus packages in our country under this umbrella, which is the participation of the union government and the state government. It's a national, national program. You talked about utilization, right? When we estimated the coverage, estimated the utilization rates in order to calculate how much per family we have to apportion the premium in the budget. Our estimate based on the NSS survey was that these 2 quintiles, 40%, okay, 2 quintiles, have a hospitalization rate of 2% per annum for secondary tertiary care based on the data of NSSO. So we thought, okay, 2%. Higher quintiles go for 4 to 5% per annum rate because they seek more care. So 2%. Today, the eligible population is seeking PMJ benefits. To begin with, actually, when we started, it was less than 2%, the first year, second year. Now, the utilization rates are 3% plus. So, पहले वो जो unmet need था, लोग जाते ही नहीं थे, NSSO में कहते थे, हाँ, admit होना है तो 2%. Now, as the access improved, the more people, 3%, today's utilization is 3% of the beneficiaries are seeking care through PMJ. So one advantage, one gain to the people is that unmet needs are being met. A study about cancer shows that those who are PMJ beneficiaries, once the cancer is diagnosed, 90% of them report within 3 weeks to the next point of care, vis-a-vis much less, 20%, those who don't have the coverage in the same group. So I want to emphasize that it's not only about out-of-pocket expenditure. Access is the first gain of such programs. And that's one of the pathways for making a difference. The original question that was raised, business of health, that you can create these pathways because care is being sought in the private sector a lot, as a proportion of the overall care with partnership of the government sector. So both are playing that role. That's number one. Number two is the out-of-pocket expenditure. Of course, out-of-pocket expenditure has a lot of angles, and there are multiple programs which are addressing it. So everything cannot be attributed to PMJ, but catastrophic expenses, yes. So the Jan Aushadhi Karikram also brings down the out-of-pocket expenditure. Whatever drugs are coming through the primary care, they are also helping and so on. But if you look at the out-of-pocket expenditure shift from 2014 to now as a proportion of total health expenditure. Madam Joshipura ji, in India, 11 years. 2014, 2013, 64% was the out-of-pocket expenditure as a proportion of total health expenditure. 2 years ago, that's the estimate that we have now, the latest will come, was 37.4%. तो कहीं से तो ये आया है, right? We believe a significant part has come out of the PMJ coverage because we can see a quicker drop after this particular program in 2018 was introduced. A study by Shamika Ravi, which looks at the expenditure related data, shows that the household stress on shifting their expenditure from food and other things to health has diminished, linked to the coverage of PMJ. So clearly PMJ has contributed, along with other Karikrams, toward reduction in out-of-pocket, but what I'm equally proud or even more proud is the fact that people are seeking care. Could any rickshaw driver imagine a coronary bypass surgery? Today it's happening. Knee replacement for a farmer? Today it's happening. Particular packages that are being used are in the space of oncology. At AIMS, the commonest package utilization is oncology. Cancer care has become a reality for poor people. Stop here.
Thank you. You know what I probably will do is take 3 questions at one time so we could integrate some of your responses. Yes, Dr. Madan.
Good morning, sir. I'm Professor Dr. Jagmeet Madan. I'm also the president of the Nutrition Science Professional Vertical of the National Allied Health Council for Professionals, which is recently being formed. Sir, I want to make an appeal to you on behalf of the fraternity that today we are trying to regulate this fraternity and get a lot of professionally qualified people on board. We are also initiating one nation, one curriculum from the coming academic year. This is basically to raise the standards of dietary practice in our country. My request and submission to you is, sir, how is it that this fraternity can engage in the most strategic way to help the nation? You know, because everywhere we feel nutrition is the base for anything to work. We may provide a lot of services under the healthcare umbrella, but unless and until we are reaching out and strengthening the nutrition vertical, I think somewhere we are missing the boat. I want to reach out to you, sir, if we can strategically plan, use technology. I'm short of words to say that we are not engaging with this fraternity nationally, you know, how it should be done, so that we can make a difference in every individual's life in this nation. To my mind, nutrition literacy is every citizen's right in this country. We are all working in silos. We are working on individual levels. You very rightly said, I work with somebody, I can make a difference in somebody's life. But why is it that this trained professional force cannot come together and work nationally from the apex body and strategically plan what is it that we can do that we reach the interior, the entire country, and make a difference in people's life? So this is my submission. In whichever way you feel, we can contribute, I will be most happy to connect and take the mandate forward. Thank you so much.
Thank you. Yeah, because I want to integrate the questions as well. Yes. I'm just taking the questions, and if you can please keep them brief. I can paraphrase for you that the importance of. Acha, or do.
Yes. Sir, what strategy would make
Could you speak closer?
Hello.
Thank
Hello.
you.
Yeah. What strategy would make community proactively seek demand for preventive and primary health services rather than waiting for some celebrating days for NCD or diabetes?
Understood.
How we can change it?
Right. Thank you. Great question.
Thank you.
Yes.
Thank you. I'm Dr. Ashwin Modi, heading one of the premier B school in Gujarat. I am again with the similar practice and the question raised by a nutrition doctor. I have the same question again to sir from the Niti Aayog. Sir, we are, and Niti Aayog specially meant for like advising the government for different things for the policy framework and many more. Any low literacy ratio for the healthcare education compared to other countries will no doubt give the problem again and again for this kind of NCDs. SEBI, one of the government regulatory body, which is looking after financial education, making more of campaigns throughout the India for financial education. Is there any plan from the Niti Aayog making some strategic formulation like nutrition literacy to have the education from the school age to the elders also? So I have a question like, for any plan or any strategic implementation through the Niti Aayog in future for the country under Viksit Bharat. Thank you.
Thank you. Can we also, I'm keeping track of this and consolidating it for you. Can we also have a question for insurance and hospital? Maybe I would like to, okay, insurance. Yeah. Sorry, I'm coming back to you. Yeah.
So, Thank you so much. This is Pankaj Bharadwaj, and I'm the director of one of the ICMR Institute in Jodhpur. So for the insurance sector, Madam, do you think that there is a regulatory gap actually, or as there are no mandatory guidelines for having a comprehensive insurance for a preventive care in insurance sector? And if you feel that if we increase, or if there is a regulation from the government or from the sector itself, that any insurance plan cannot be rolled out if there is no comprehensive preventive care package, would that increase the penetration and the reach of insurance sector from being more reactive to proactive? Thank you so much.
Thank you. So now maybe we could respond first, otherwise I'm going to lose track of the questions. I think consolidating the questions here is, what are the plans for nutrition literacy, financial literacy, and health literacy? That's what I got in the umbrella. And also an appeal to really engage the nutrition professions right from get-go, because it's the foundational behavior change, as you also said, from throughout the life cycle. So that was one question. And then for you, I think you heard the question clearly, but also going back to the previous question is the insurance coverage for outpatient versus inpatient. Why is there not sufficient coverage for outpatient? So these are the summarized versions of the question.
The short answer. Ma'am, you said that nutrition literacy is important. Indeed it is. And it was always important. By the way, let's not forget that there is an agenda of undernutrition. I want to remind how the nutrition literacy is missing there. In fact, substantive point I make in that regard. Anemia, I want to make a point. So it is needed, and hugely needed. I look forward to working with nutrition, enablers, workers and stakeholders in a big way. We need to rise to the occasion. Don't wait for anybody to do it tomorrow. And let me now put some incisive points in this regard. Under nutrition, I want to start. And I find that nutrition community does not respond optimally. This is from my side now. Child undernutrition has 3 mothers. 1, I'm born small, determinants are in the mother, epigenetics, adolescence, and so on. Udhar nahi aaj jayenge. About 25% of undernutrition that you see later on through surveys, under 5, comes from there. 25% comes from infections, diarrhea, pneumonia, HIV, health conditions, etc. We are left with about 50%, which is nutrition. Now, food availability is a non-issue. Food is same for the child, except it is to be prepared differently. I'm teaching it to the nutritionists. It's the same food. The food groups are the same. वही rice, वही wheat, वही दाल, वही सब्जी, वही आलू, वही दूध, वही sugar, वही oil, वही egg. A study in Tamil Nadu, I want academic presence here, it shows that from CMC Vellore, the food, let's say, the mother is consuming cereal to the tune of 90%. Child who should be consuming cereal is 40%. For milk product, it is the same. Child is also given milk, the mother also takes milk. For egg, mother consuming, this is Tamil Nadu, to the tune of, let's say, 30%, child 6%. The point I'm making is, घर में खाना है, लेकिन वो खिलाया नहीं जा रहा. ये behavior issue है. Huge behavior issue. अब मैं statistics देना चाहूँगा, because nutrition is very close to the government and to me personally. Hear me out. Why behavior change is missing, we need those powerful tools. Breastfeeding rates. Exclusive breastfeeding 6 months. By 5th month, Indian overall, in FHS 5, 49%, 45% breastfeeding remains exclusive. Starting 90% in the first month. Why? And low birth weight baby feeding is another issue. Stop there. After 6 months of age, semi-solid food called complementary food has to be introduced. Wahi khichdi, wahi aloo, wahi kela. 6 to 8 months. Introduction. Muh mein lagana. Thoda sa effort karna. How often are we doing it? 49% times. And when we are saying 49%, it means sampann parivar. Hum mein se bhi yahan hum shuru nahi karte. Behavior problem. So the poorest don't start complementary feeding between 6 to 8 months to the tune of, let's say, they start to the tune of 40%, and the richest start only to the tune of 60%. Not much better. Now I'll come to a shocking number. The optimality of complementary feeding in surveys is assessed by 2 parameters. Food groups, which I stated just now, and frequency of feeding. You know it, ma'am. 3 times to 4 times below 1 year, and then 4 times or so after 1 year. If you combine this, there's a metric called minimum acceptable diet. Minimum acceptable diet is a metric combining the food groups, which mean different balanced food items, coupled with amount of salt. This is not actual calculation of energy intake. So minimum acceptable diet adequacy, prevalence of optimum minimum acceptable diet, 11%. Only 89% of our children are not getting minimum acceptable diet. The best record, Odisha, 21%. Second best, Himachal Pradesh, 19%. So 89% of our children, which obviously would mean that the richest also are not optimizing it. Is it food availability? No, behavior change. Where are we? Richest, that 11% is the average. Richest, compliance with minimum acceptable feed, 14%. Only. So the richest 86% also don't feed their children with frequency and amount. Consistently, NFHS 3, 8%, 4, 9%, now 11%. It's a behavior issue. And the poorest, 14%. No different.
Wow.
There's something wrong in our discourse. बच्चों को नहीं देना है, बच्चे का पेट छोटा है. Now here, my request is, ma'am, even the nutrition community has never talked about this. I don't hear this being a discourse in nutrition meetings. When have we done this the last from nutrition associations? Humble submission, please जरा ध्यान से देखिए. NCD में मोटापा कम करना तो और भी मुश्किल है. कम से कम ये बच्चे को कमज़ोर देखते हैं तो डिस्कोर्स बना हुआ कि दिमाग कम हो बन जाता है. Height at 2 years is half of the height of an adult, you cannot change it. The damage is done. Cognition happens in the first 2 years, 3 years. उसके बाद तो कम speed हो जाती है. The point I'm making is behavior change is the key. And please, you need it for obesity, others will speak on that. And we said on scale, behavior change is so difficult, but we have to crack it. There are nudges. Japanese society doesn't do it this way. They use small portions, for example. And why we children are not getting food? Last point on this, anemia, I want to flag it. We are in School of Public Health. 55% of women, this is more recent data, NIN friend is sitting here, which is same as NFHS, so it's the same thing. 50% of our women are anemic. पता नहीं फर्क पड़ता नहीं है, हम चल तो रहे हैं. It's a norm. But what is important is half of them, 1 out of 4 here in this room, I can tell you, is anemia, moderate or severe. Severe wala yahan nahi hoga, is less than 10. Less than 10 hemoglobin will not give you enough energy to do household chore or to sit in the office of an insurance company or in Niti Aayog or in AIMS or a teacher or a worker. There is a price we are paying. Anemic children cannot do geometry in particular. हमने इसको change नहीं किया. So the point, this I'm flagging because it has behavior, but there are other things also into it. Anemia is a little more complex, but just want to return to the fact that nutrition literacy is needed. We must join hands, and we should be driven by some of the key things in the discourse and discussion, which Definitely in the space of undernutrition, I have had a great difficulty in changing discourse. Nutrition policy, severe acute malnutrition when the child is born, तो सब प्रोग्राम है कि पकड़ो उसको ठीक करो एनआरसी में लेके जाओ. वो हुआ क्यों? क्योंकि उसको फीड ही नहीं शुरू कराया आपने 6-8 महीने में. उसको ब्रेस्ट फीडिंग पूरी ही नहीं हुई. वो लो बर्थ वेट को और सेवा करनी थी, वहाँ फेल हो गए. कैंगरू मदर नहीं किया तो वो एसएम बन गया. This discourse must change. Please, the rates are changing secularly, only about 1% for stunting every year. The gain in stunting are largely coming from a reduction in infections, and they will happen even more with Swachhata. I expect a very dramatic decline in wasting. Stunting perhaps will nudge a little bit because of these things. So food habits, food optimality, please talk about it. We are cereal-based food, the bulk is too much. Right? Energy density, you add fat so that you get more energy in the same small portion, not being talked about by nutritionists. Please don't mind it. But I think this is at the heart of our issue, and we must join hands, get the evidence-based indicators. How often have you seen an advertisement on complementary feeding or breastfeeding? कभी देखा कहीं पे? पोलियो पे दिखता है, कोविड पे दिखता था, शायद सिगरेट पे दिखता है कभी कभी. बच्चे के खाने पे दिखता ही नहीं कभी. सबको जुड़ना होगा. इसे जन आंदोलन, प्रधानमंत्री जन आंदोलन कहते हैं कि न्यूट्रिशन की बज़ होनी चाहिए. पोषण जब बना था उन्होंने कहा जन आंदोलन. वेयर इज द जन आंदोलन फॉर अंडर न्यूट्रिशन? ऑफ कोर्स इक्वली इंपॉर्टेंटली वी नाउ नीड जन आंदोलन फॉर दैट, एंड वी मस्ट एड्रेस इट. सो नो डाउट अबाउट इट. न्यूट्रिशन लिटरेसी, जन आंदोलन, बिहेवियर चेंज, नचेस, इसके ऊपर हमें काम करना होगा. स्कूल के बच्चे इंपॉर्टेंट है, बहुत ही इंपॉर्टेंट है. वहाँ लास्ट अपॉर्चुनिटी है कुछ बिहेवियर चेंज करने की. उसके बाद तो खराब ही होना है. आसान नहीं है बाद में चेंज करना. विद ऑल दिस स्क्रीन टाइम एंड स्लीप एंड मेंटल, वो कहाँ स्पेस रह जाता है. प्लीज़ लेट्स जॉइन हैंड्स फॉर अ बिग बिहेवियर चेंज फॉर न्यूट्रिशन. थैंक यू.
Thank you. That's a very comprehensive view of everything you've presented. I want to give all of us a time check. I have about 12 to 15 minutes at the most, and I do want to take questions for the other speakers as well. So I'm going to take 2 more questions after Dr. Nandargi responds to her insurance questions.
Yeah.
So,
If I have heard correctly, I think it was about
Perhaps.
why OPD insurance,
if you prefer this. Yeah.
why OPD insurance is not much prevalent as compared to the inpatient coverage. See, there are 2 aspects. One is the inpatient coverage is less in frequency and high on severity. The payments or the outgo is high in inpatient, and on the other way, the outpatient treatments is high on frequency and low on severity. So that ways the premium, when we work out the pricing for both the things, the inpatient is much unpredictable. It's highly unpredictable. So the insurance is mainly designed for the unpredictable conditions, to take care of the unforeseen and unpredictable conditions. Whereas outpatient is mostly predictable. We know there are infections, we know there are smaller conditions for which the person goes for consultation high. So when we look at the pricing of the product, if by covering OPD into insurance, the pricing goes up significantly, and the utilization is also high. Having said that, in last 3 years, we have seen across insurance companies and products, there are plans which cover the outpatient coverages also, and to some extent, we have started covering the dental coverage also. And obviously the preventive health checkup is inbuilt now annually in most of the plans. But we are still observing how the utilization is happening on the outpatient, how we can rationalize it. And the biggest problem for the insurance companies is the fraud and abuse, because outpatient consultations and the bills and the pharmacy bills, the investigation bills in India are very easily available. So we see a large amount of fraud coming in. So people who need genuinely are paying for these kind of things. So we are trying to see how to curb these things with the help of AI, as you mentioned, and also to see by data analytics where and how we can control these things and rationalize the pricing to make OPD as an integral part of all the plans. Yeah.
All right, I had interrupted one gentleman, so I'll go back to that question, and perhaps you at the back. So could you say, yes, your question, please?
My name is Ashok. I work at the intersection of technology, specifically AI, healthcare, and child education work. My question was to Dr. Paul. Tremendous amount of good work done with the government machinery, understand the challenges which government faces at a scale of India's population. Mamta, polio eradication, all great work. I want to just refer back to the catch them young point, specifically with regard to the childhood obesity. In Western countries, many countries, there's a missionary zeal to curb down the sugar and the ultra-processed foods, right? Specifically with food packaging. I know we have to respect the market, give the freedom, but in a country where a fitness expert becomes a gutka ambassador, I know the challenges, but any thoughts on this where we can try to get a fine balance, especially with packaging for the young kids, which can affect long-term implications?
Thank you. I'm going to take a question at the back. Yes, you ma'am, yes.
Good morning. I'm Dr. Aparajita Shukla. I'm from Community Medicine. I'm heading the Department of Community Medicine at NHL Municipal Medical College here in Ahmedabad. Thank you for this opportunity to communicate. As I know very little about public health so far, in spite of being in the field for almost 3 decades now, my questions are also very simple. According to me, I think 2 most burning issues here in public health, one is the data, the accuracy of data that we have, because what we see in the field and what we see on the records have a lot of discrepancies. So maybe we can do some leveraging on the family adoption programs that have started in the MBBS curriculum now. The MBBS course has now started with the family adoption programs, and we are in contact with the families for a long 5 years period. So can that data be used? I think our Association of Indian Association of Public Preventive and Social Medicine started doing that along with the government. So we can strengthen that. Second and more burning issue according to me is the quality of training that is happening in not only MBBS but all other allied and paramedic courses. So nobody so far is talking about the quality even during the inspections. So I think because that's the point of care, even in medical, even in the PHC, a medical officer is trained in a medical college. So he is the one who is not only diagnosing and treating, but also communicating with the patients. So it makes a lot of difference how he communicates, and then a lot of preventive care can take place. My issue is what is being done for ensuring the quality of training.
Thank you. Thank you. I'm going to take one more question, and I'm really sorry I might not get to everyone's questions, but this is all we probably have time to respond to. Go ahead.
Yeah. Thank you, Niyati. I'm Neha Rati, visiting professor at the Bakshi School of Public Health. I'm happy to take the bash because I'm a behavioral nutritionist. So we are at Ahmedabad University, contribute Prime Minister's Jan Andolan by introducing a course, Skill 100, SKL 100, which actually delivers both procedural as well as declarative nutrition knowledge, which is an important component of both food and nutrition literacy. If this works, so we are having 125 students in the first batch. If it works, I'm happy to scale it up in a school and then perhaps share the data with Niti Aayog and other ministries where nutrition is important. Thank you.
Thank you. So recapping those 2 questions, one was about front of label packaging for ultra processed food. Okay, and the other one was
I got the
trained
question.
deficit.
So thank you very much for these initiatives. When I was getting into this discourse, coming very passionately, really requesting the nutrition fraternity to really get those messages right. Please, we do a lot of things, but उतना emphasis लाने की ज़रूरत है pediatricians को भी, जनरल डॉक्टर्स को भी ऐसे कोर्सेज हों, और ये इस इंडिकेटर को हम हर साल लेते हैं, तो उसके पीछे चेज़ करना है, आपने भी करना, ICMR ने भी करना है, AIMS ने भी करना है. So it is because, you know, the pain of this recalcitrant problem where we are stuck. So apologies if, you know, I went a little bit more than my usual, you know, restrained self. Data, I think point taken, that's more like a suggestion. The issue with regard to quality of training, I think the onus on this, of course, is on the regulator and the government, granted. But ये करना किसने? Why these things are not being done by the faculties of the respective medical colleges? जरा ये सोचिए. Regulator ने लिख दिया ये होना चाहिए. AdCom मॉड्यूल भी बना दिया. तो यहाँ मैं यही humble submission करूँगा. Responsibility of the NMC and the government doesn't go away. But I humbly request that these issues of skills, let's say non-optimality in certain situations, ये हमें as faculty करना है, as teachers करना है. So please, I urge that a much more important, much more effort comes out from our faculty. I can imagine there are faculty vacancies, मिल नहीं रहे, that constraints are up there. लेकिन एक कहा जाता है कि एक सर्जन उतना नहीं उसको आता, तो पास क्यों कर रहे हो आप? पास कैसे हो जाता है अगर स्किल नहीं है तो? ये किसने करना है? बेंचमार्क बोले हैं कि MBBS को ये नहीं आता, बच्चे को काउंसलिंग नहीं आती, कॉम्प्लीमेंट्री फीडिंग नहीं, तो पास कैसे हो रहा बच्चा वो? ये भी तो सोचो ना. तो मैं कहूँगा कि उधर भागीदारी इधर भी है और उसको अपॉर्चुनिटी दें. डू वी डिवोट टाइम ऑन द बेड साइड एनफ एज टीचर्स? डू वी एंगेज सीनियर रेजिडेंट्स टू टीच आवर स्टूडेंट्स? सिर्फ मेडिकल कॉलेज एजुकेशन इज नथिंग टू डू विद दीज रूम्स. यू नो, ये इस यूनिवर्सिटी में चाहिए इतने बड़े बड़े कमरे. मेडिकल कॉलेज में वो ठीक है, वो टेंट के नीचे भी पढ़ा लो, बिकॉज दैट इज ओनली एन ओरिएंटेशन. एवरीबडी इज रीडिंग ऑन देयर ओन. Our teaching is the bedside teaching, in the outpatient, in the inpatient, in the operation theatre, in the and not only between 9 to 5, 12 o'clock midnight, 3 o'clock in the morning. Particularly for specialists, even more intense like that. तो ये जिम्मेवारी जो मेडिकल टीचर्स के ऊपर है, मैं humbly रिक्वेस्ट करता हूँ कि प्लीज़ इसको निभाइए. करिकुलम में कोई कमी नहीं. रिसोर्सेज वीडियो पे अवेलेबल हैं, अब तो सब डेमोक्रेटाइज हो रखा है. आर वी वर्किंग हार्ड? डू चिल्ड्रन हैव दीज क्लासेज इन द इवनिंग? डू वी टेक देम ऑन द राउंड? डू वी डिवोट इनफ टाइम ऑन द बेड साइड? डू वी टेस्ट इट अकॉर्डिंगली? बिकॉज स्टूडेंट्स लर्न व्हाट दे आर आस्क्ड इन द एग्जाम. तो थोड़ा सा इसमें सबकी भागीदारी की ज़रूरत है. मैं चाहूँगा कि उसको उस दशा से भी देखा जाए. ऑन द इशू ऑफ फ्रंट ऑफ पैकेज, so that's one tool we have, regulatory tool for businesses to be responsive. Okay, regulatory tools, incentives, disincentives, and so on, and strategic use of the positive product. These are the tools that connect business to be responsible business, etc. It's valid. This discourse is on very actively, as you know. Economic survey of last year brought it out very well. There is some response on the GST rates, as you may have seen. So this is on the table. There is on this advertising, which is a related aspect, there is a zero tolerance, and there is a portal where if you see an advertisement which is misdirected, kindly bring it to the attention. I know the commitment on FSSAI is profound on that. So that is being taken forward. Please be vigilant if somebody is putting those advertisements. So it's a clear. Now, with regard to HFSS, labeling and UPF, as I said, the discussions are on, but there are one or two constraints.
Could you hold the mic closer? Thank you.
One constraint is, how do I define an ultra-processed food? HFSS, only very recently NIN has brought out the norms, and they can be adapted, so there is a progress. But on the ultra-processed food, there is a NOVA classification, and the ICMR uses the same classification, very generic. Processed and following additives added, disruption of this kind in fiber. These are generic. Company will say, मैंने 0.1% वाले को या 1% कौन सी चीज, that, you know, that specific things in terms of quantification, generic, yes, this is UPF, that chips looks like ultra processed and all that. Lekin on what criteria? That precision of definition of UPF is missing. Even the Lancet discourse brings out the same NOVA classification. I'm urging ICMR, I'm urging FSSAI, we had a meeting with them, that we need to be precise. Suppose they say you add additives and emulsifiers. How much amount? Which emulsifier is strong? Because industry would then like to know this has to be excluded, right? So that level of precision which is required to classify it yes or no in the UPF space is right now missing. Overall, everybody knows. But if you ban somebody to market or you ask them to put a huge label, the question will be asked, kis criteria pe? Okay? Codex has precision for many things, but isme nahi hua. So UPF categorization needs help, and I think we only have to do it ourselves together. So there is that little, I would say, technical inadequacy in the discourse. For HFSS from the NIN, the data, the upper caps are now available, and the discourse should happen in taking everything into account, and we need to move in that direction seriously. Thank you. It's work in progress.
I really apologize. We are out of time at this moment, and I want to end this panel by giving you two key takeaways. One is to reframe the business of health by aligning incentives for public good. And really, secondly, from all the examples that you've given, it's evident that we need cross-sector partnerships that are essential for these types of dialogues to continue. And I'm really thankful that we've been able to share this platform and start the dialogue, but I think there's much more to come and many such conversations needed. So with this, I want to thank each panelist for your thoughtful insights and bringing such depth and breadth to today's discussion. And just to enhance our understanding of the business of health and how it can achieve equity and impact in the larger population. We're so grateful for your time and expertise, and I'm closing this with a big round of applause to you. Thank you. I now, all right, I think he's telling us.
I request Professor Kaumudi Joshipura, the Dean of the Bhakti School of Public Health, to present a reiteration of the agenda and the brief concluding remarks, and also the delightful duty of presenting our distinguished guests with memento afterwards. Thank you.
Thank you all for a wonderful panel discussion. It was really very insightful, and we have a lot more to do. So this is for the audience. I know there are many, many very dignified, qualified people with lots of information who can contribute to this. So please reflect on the panel discussion, the questions, the thoughts, etc., and write to us. You can scan the QR code and there's an email address. So please write to us with your thoughts. How would you like to engage? We will continue this dialogue. This is just the beginning. So in the afternoon, some of us will be going with the invited experts into deep dive discussions. So this is kind of a setup for what we can discuss in much more detail on some of the topics that were touched on. Obesity, obesogenic environment, how can we work across different agencies. Another one would be on strategizing social media and marketing strategies. Ultra-processed foods that we talked about. So we'll have different roundtable discussions with 6 to 8 people in each roundtable. And then we also have a one on primary prevention through cross-institutional partnerships. I take the point from Dr. Paul that yes, it is very hard to do in practice and there may not have been so much success to date, but we have to keep trying.
Can I intervene? So here is a request, and government can help in this. please adopt 10 health and wellness centers. So this will be 50,000 population. As School of Public Health, adopt 10 health and wellness centers and demonstrate the optimum implementation of all the 12 packages. Of course, the major ones are around NCD today. You can focus more on that. Even the NCD package, can that be shown to be optimally implemented in all its dimensions, both primary prevention, secondary prevention, and then pathway, and so on. So let us demonstrate that this can be done. And that will be a great contribution, sir, because karke dikhaye na, system ban gaya hai. That changes the paradigm. Policy may demonstrating a change of best practice and measured in an academic way will change the paradigm. So take finite population and show the proof of principle. Thank you.
Yeah, absolutely. And it's not just the what, but also the how, which is very challenging. And I was just thinking, hearing all the comments, that if we all come together, all health professionals, government, insurance, hospitals, everybody, take 2-3 simple messages and just, there's information gaps, there's messaging gaps. I think if we take one message a year and just push that, you may not be able to, exactly see what the impact is, but there is a positive impact of all these that may be hard to quantify. So we have to work scientifically, as well as there's a lot of things that are already proven and already work, and to push those along. So yeah, and we have a roundtable on policies to have win-win outcomes for business and health. I think the whole goal throughout this is to integrate the businesses with the academics and cross-sectionally, cross-sectorally. And also one on innovations, including AI, technologies, and new opportunities. So we have many different institutions represented, both from the private sector, from ICMR, from many different sectors, IP Global, food companies, hospitals, and diagnostics, technology, a lot of different organizations who have been represented and will continue into the roundtables. And as we are here today, and we all know this conversation could go on the whole day and even longer. We could have a week-long retreat, and there's so much to talk about. So coming together is an important beginning. It's great to have so many diverse people here in the room. And we go forward, we will continue the dialogue, and we will keep everyone engaged and bring more people to the table who may be missing here today. So this is not the end, this is the beginning.
Professor, please.
Yeah,
please
I just
stand.
want to.
Do you want to conclude?
No, I just want to give some.
Yeah, so I'm announcing.
Okay, sure.
If you could stand there. May I request Professor Joshipura to present Dr. Vinod Paul with a memento, please? And now to Dr. Rashmi Nandargi, please. Thank you. Dr. Atul Mohan Kochar. And of course, Professor Niyati Parekh, our outstanding moderator. Thank you very much. And if I could trouble you, ladies and gentlemen, to just remain in appreciation of, do be seated. I'll just take a minute. This is really a thank you for all of us coming together. And I have to thank our 3 distinguished panelists, Dr. Paul, Dr. Nandargi, and Dr. Kochar, and of course, Professor Parekh and Professor Chandra for believing in the idea of Ahmedabad Dialogue. Thank you very much. Dr. Rajendra Gadvi for his tireless work behind the scenes. Thank you, Doctor. Our colleagues at Ahmedabad Executive Education, Anindya Maitra and Mehak Sareen, Mukesh Patil of Campus Operations, our colleagues at the Bhakti School of Public Health, Shibashish Das and Saharsh Panchal, all our volunteers, and all our roundtable contributors who will, of course, take forward this morning's thoughts and guidance and discuss their own thoughts and contribute their own thoughts to set an actionable agenda. The university's information and audiovisual teams, our colleagues in the communications team, media persons who are with us today. We thank very much the members of Ahmedabad University's Board of Governors and members of the Board of Management who are with us and also with us in spirit, and of course all of you, the audience. Thank you all for your support and presence. We hope to soon share with you the outcomes of the Ahmedabad Dialogue on the business of health, and also to welcome you back at the next Ahmedabad Dialogue, which we shall soon announce. Good afternoon and good day to you. Well, I sort of wove that in.
उठा लो ये कार्ड में कहाँ पे है
So are you doing something right now on this?
Yeah, I'm going to focus on it, but I'm more interested in
अच्छा
development that
बात कर रहे हैं
yes, most
बात कर रहे हैं
but I can write down my number for you.
I think I'll also connect you with our communications.
Yeah, I'm already
क्या
there
करना
with
है
it. 98257 Brendan, BRENDAN.
Okay, wonderful.
Yes. What if you can tell me your number?
Yeah, 9324241167.
It's nice now to have two schools of public health, you know, in Gujarat. Yeah, constantly connected to IPH, public health. I had come for the inauguration of your school. Yes, but after that I'm coming only now. So I'd like to be more in touch. I won't keep you though.
Yeah,